Welcome to your teaching session on the difference between a child and an adult, specifically looking at the physiological differences and some of the anatomical differences. Structure is very important for this question, so we'll look at each system in turn. So let's start off by looking at the respiratory system. So starting on with the airway, children have a larger head, they have a shorter neck and a very large tongue. The nasal passages are also very narrow. Compared to adults, they have a higher anterior larynx. So the level is at C2 to 3 in comparison to an adult, where the level will be C5 to 6. Children also have a very large floppy epiglottis, which can be visualized during intubation. The narrowest point of their larynx is the level of the cricoid cartilage. And for an adult, this is at the laryngeal inlet. Small airway trauma in a child can result in a large airway obstruction because their space is small anyway. Now moving down into the trachea and the bronchus. In a child, there's an equal angle between the main bronchi in comparison to adults, where the right bronchus is more vertical, therefore more likely to where a foreign body to dislodge in. Child has a more of a fixed tidal volume, so most of the compensation occurs by changing their respiratory rate. The closing volume is also higher than FRC until the child is 6 to 8 years old, which will mean that there'll be airway closure at the end of end expiration. Children have a higher risk of desaturating, and this is also due to increased oxygen consumption related to increased metabolic rate. Children also have a high risk of having apneic episodes. So now let's move on to looking at the cardiovascular system. The circulating blood volume in a child is about 85 mL per kilo, whereas in an adult it is 70 mL per kilo. Children tend to tolerate bradycardia poorly, so it can result in cardiac arrest. Bradycardia also occurs quite frequently because the parasympathetic nervous system is better developed. Stroke volume is relatively fixed, so again, children compensate by increasing heart rate. Cardiac output is about 200 mL per kilo per minute. Asystole is the most common form of cardiac arrest in children. Neonates have a higher hemoglobin of about 16 to 20 grams per deciliter. So that's their HB. And there is a variety in the normal heart rate and blood pressure of children of different ages. Now let's move on to looking at the central nervous system. The skull is a non-rigid metal box in neonates with open fontanelles. The MAC of an infant is greater than a neonate, which is greater than an adult. Children tend to be more sensitive to opioid-induced respiratory depression and apnea. And the spinal cord ends at the level of L3 in a child, which will be L1 by the time they're 2 years old. When we look at the renal system, we know that children are born with higher total body water at birth, so about 80%. There's an increased extracellular fluid resulting in high volume of distribution in children. Renal immaturity means that children are poor at handling excess water or sodium, and glucose reabsorption is limited. And this tends to be very early on in life. GFR at term is about 30 mils per minute and increases to 110 mils per minute by the time a child is 2 years old. Children have an immature liver, which will result in having poor function, so especially when we look at metabolism of drugs, so they'll have less metabolism and less hepatic glycogen store, so hypoglycemia can occur quickly. So this is a quick overview of some of the physiological and anatomical differences between a child and an adult. There are some that are more relevant to, for example, in anaesthetics, looking at higher MAC, so aiming for higher MAC in children as per their requirement, knowing that a child might not be able to metabolize drugs due to having an immature liver, a child having a higher volume of distribution, again when thinking about administering drugs, a child having a floppy epiglottis or high anterior larynx, and also having closing volume that is greater or encouraging on FRC, especially before the age of 6. And how a child cannot compensate in terms of increasing the stroke volume. It's relatively fixed, so they tend to compensate by increasing their heart rate. They're more prone to bradycardia as a result of their parasympathetic nervous system being more developed in comparison to their sympathetic nervous system. And also in terms of looking at their respiratory system, they tend to compensate more by increasing the respiratory rate to increase their minute ventilation. Thank you for listening, and I'll see you for the next session.